academic topic, that is common gynecological problems in day-to-day practice. And it is a very good move on the part of IMEKSP. I really thanks to our chairperson, subcommittee academic, Sanjana Tallur, and also all the members of the subcommittee, and our secretary Karnakar, and past president Madhusudan Karignur, and Darish Bettu, Dr. Anita D, and Dr. Rajesh Madam. And we have got a very good speaker like today. We have got Anita Gaura. Gaura, yeah, Anita Gaura. And I heard from Sanjana Madam. She is a very good writer and also the speaker. And it will be useful for us because every day we are seeing so many cases with problems, so that we can very well treat. And if you don't have a facilities and diagnosis, we can send it to a particular time to a specialist. In that connection, we have got a chairman, Shubharani Kadapatti from Milkal. Anita Gaur is from Kalaburgi. Topic is also very good, common and useful topic. And I welcome them. And also I wish them all the best. Make use of it. I request all the members to make use of this talk. So with this forward, I hand over this to Madam Sanjana Madam.
Thank you, sir. Thank you for your kind words. Now, without taking much time, I'd like to say a few words about Anita. She's young and enthusiastic gynecologist, and also other part of the CV will be read by Dr. Shubha Kadapatti, who is a chairperson. So she's a consultant. Shubha is a consultant at SS Kadapatti Hospital at Kilkal, and she's a present IMA secretary. She has conducted many camps in regards to health and also gives education to the rural women. Right now, she's practicing at SS Kadapatti Hospital, Kilkal. So this topic we have chosen because it is an IMA platform, and many will be like practicing in the rural areas. So let us have a few highlight about gynecological problems. So Shubha. Hello, Dr. Shubha.
A very good evening to everyone. My regards to IMA President Lakol sir and Secretary Dr. Karnakar sir and Dr. Madhusudan sir, and special thanks to my friend Dr. Sanjana, who has given me an opportunity to be a part of this session. And I would like to say good luck to Dr. Anita, who will be the speaker today. And I want to tell everyone that I am an alumni of MRMC Gulbarga. So I once again welcome all the delegates. So now introducing Dr. Anita Gaura Konin. She is Assistant Professor, Department of OBG, MRMC Kalaburgi, and she is Treasurer, FOXY, and member of Kasoga Violence Against Women Wing. And she has been a speaker at many CMAs and webinars and has been panelist for various sessions. She has presented poster at World Congress FIGO 2021, and looking forward for a great interactive session. Thank you. Over to you, Dr. Anita.
Thank you, ma'am, for that introduction. Without wasting much of our time, we'll begin with today's session. And just share the slide. Good evening, everyone. I'll be discussing common gynecological problems in day-to-day practice. So a woman's lifespan is divided into pediatric age group, adolescent age group, reproductive age group, and the menopause age group. And depending upon these various stages, we come across various problems she encounters in her life, and the reason for her visiting to the gynaec or a general practitioner OPD. Beginning with the adolescent age group, the age group between 10 to 19 years, or we say the teenagers, or beginning from the menarche to the 19 years of age is called as adolescent. So common conditions which a girl or a teenager who wishes to see a gynecologist or a doctor are dysmenorrhea, premenstrual syndrome, and menstrual irregularities. Starting with dysmenorrhea, it means cramping pain accompanying the menstruation or a painful menstruation. So it can be a primary dysmenorrhea or a secondary dysmenorrhea. Primary dysmenorrhea does not have any pathology. It affects more than 50% of the post-pubescent women in the age group of 18 to 25 years. More than 50% of the teenagers have dysmenorrhea, and it is severe incapacitating type, which occurs only in 5 to 15%. Secondary dysmenorrhea is the one where there is a underlying pathology like endometriosis, adenomyosis, uterine fibroid, or pelvic inflammatory diseases. Secondary dysmenorrhea can be iatrogenic also when the woman is using an intrauterine contraceptive device. Unilateral dysmenorrhea occurs in rudimentary horn of a bicornuate uterus. So clinical varieties, it can be a spasmodic dysmenorrhea, congestive dysmenorrhea, or a membranous dysmenorrhea. Spasmodic dysmenorrhea is the one which starts on the first day of the menstrual cycle. It will be there for 2 to 3 days. After that, it regresses. It is the most common type of dysmenorrhea. Congestive dysmenorrhea is seen where the pain starts a few days prior to a menstrual cycle. As soon as the menstrual cycle is set in, the pain regresses. So it is commonly seen in pelvic inflammatory diseases, intrauterine contraceptive devices wearers, pelvic endometriosis, and fibroid uterus. Membranous dysmenorrhea is the one where the whole of the endometrium is shed as a cast with a painful uterine contraction. So what is the etiology of this pain? It will be uterine hyperactivity, that is myometrial contractions, uterine ischemia, or sensitization of the nerve stimulation. Most of the dysmenorrhea is seen in the ovulatory cycles. What happens in ovulatory cycle is there is formation of corpus luteum, which releases progesterone. Progesterone increases the prostaglandin release, and this prostaglandin causes the pain. So distinguishing features between primary and secondary dysmenorrheas. Primary dysmenorrhea is seen just after the NR for around 2 to 3 years. It is cramping pain at the hypogastrium, back, and the inner thighs. It can be associated with nausea, vomiting, diarrhea, headache, fatigue. Pelvic findings are normal because there is no pathology. It is just because of the excessive myometrial contraction, ischemia, and excessive prostaglandin production. Treatment, it can be managed with reassurance and analgesics, NSAIDs, and antispasmodic. Whereas secondary dysmenorrhea occurs in the second or third decade of the life, or even pre or post-menstrual period, and it's variable dull age. It has associated complaints of dyspareunia, infertility, and menstrual disorders. Pelvic findings, depending if there is a fibroid, a mass can be felt. Endometriosis, again, nodularities can be felt in the pouch of Douglas. And the etiology is endometriosis, pelvic inflammatory disease, adenomyosis, fibroid, and pelvic pain congestion. Management is treat the underlying pathology. So what are the clinical features here? There is uterine cramping, nausea, vomiting, backache, diarrhea, giddiness, syncope, and fainting. It is responsible for the highest incidence of absenteeism, resulting in loss of work hours and economic loss. Coming to the investigation, ideally a pelvic sonography, ultrasonography is enough for diagnosing if there is an underlying pathology. When needed, CT scan or MRI scan is done. Diagnostic hysterosalpingography or sonosalpingography. This is important when there is a uterine anomaly or a Mullerian anomaly to diagnose this, or if there is an endometrial polyp. Endoscopy, diagnostic hysteroscopy or laparoscopy. Hysterolap can also be used as a therapeutic. Whenever we find a pathology, it can be treated along with hysterolap along with diagnostic. It can be therapeutic. Coming to treatment, analgesics like paracetamol, antispasmodic like hyoscine, which can be given thrice daily, or camilofin, which is available as anaphortan, which can be given thrice daily, or trotaverin. Non-steroidal anti-inflammatory drugs like mefenamic acid, 250 to 500 milligram thrice daily, indomethacin, naproxen, ketoprofen, or ibuprofen in the dosage of 400 milligram 8-hourly can also be given. Progesterone containing IUCD like Mirena are also helpful. Oral contraceptive pills can be administered cyclically to suppress ovulation. As we told that etiology is which is more common in the ovulatory cycles. So if we are by giving oral contraceptive pills, we can suppress the ovulation, and that will in turn take care of the prostaglandins. This is very helpful. Even it can be a mode of contraception for the woman. Pelvic endometriosis can be treated with increasing doses of danazols or UC pills or GnRH analogs. Coming to the surgical management, especially helpful when there is an endometrial polyp or a fibroid or a septum that is seen in uterine anomaly. So diagnostic hysteroscopy followed by dilatation and curettage, excision of a polyp or a uterine septum. Diagnostic laparoscopy followed by lysis of pelvic adhesions, myomectomy or draining of chocolate cyst, or laser assisted uterosacral nerve ablation for spasmodic dysmenorrhea. So laparotomy is considered when laparoscopy is not available. We can still go for laparotomy to again excise the chocolate cyst, eradication of endometriosis, and myomectomy. Hysterectomy is considered only in elderly women when she has completed her family and medical management has failed. Transcutaneous electric nerve stimulation is effective in 45% of the cases. Coming to next problem, premenstrual syndrome. So it is also called as PMS or the premenstrual tension. It is a symptom complex recognized primarily by cyclical changes associated with ovulatory cycles. It occurs 7 to 10 days prior to menstruation and spontaneously resolves after menses. So what are the problems? There can be pain, like pain can be headache, breast pain, abdominal cramps, muscle stiffness, backache, and generalized body ache. Water retention, it can be in the form of breast pain, bloating, weight gain. Behavioral changes, low performance, difficulty in concentration, irritability, depression, forgetfulness, low judgment, anxiety, loneliness, feels like crying. Autonomic changes like dizziness, faintness, nausea, vomiting, and hot flushes. All these symptoms are mainly because of there is a change in the estrogen-progesterone ratio. There is fall in the serotonin and endorphins levels. So how to treat it? First, lifestyle modification. She can go for walking, yoga, meditation can help some people. Psychosomatic changes can be treated with multivitamins, which includes vitamin B1, B6, and vitamin E. Selective serotonin reuptake inhibitors like fluoxetine in the dosage of 20 milligram a day or sertraline 50 milligram a day can be given. Breast weight can be treated with danazol, bromocriptine, or GnRH analog. Pelvic pain and bloatedness, OC pills containing drospirenone, that is yasmin, can be used, which is also mineralocorticoid, which will reduce her water retention. Coming to the next problem, which leukorrhea, which will be present in the adolescent age group also and reproductive age group also. So physiological leukorrhea is generally present, which is a normal vaginal secretion which is increased in amount. There will be no excess leukocyte present when the discharge is examined under microscope, and the discharge is macroscopically or microscopically non-purulent, so that there is no infection. Physiologically, it is seen at puberty due to increased vascularity of the uterus, cervix, and vagina. It is also seen during pregnancy because of the increased vascularity of the female genital tract. At the time of ovulation and in some women during premenstrual phase of the menstrual cycle due to hypertrophied glands of the endometrium. So when it is excessive cervical secretion can be even from the cervix. Conditions like chronic cervicitis, cervical erosion, mucous polyp, and ectropion. Excessive vaginal secretion, transudation through the vaginal walls. Causes of increased vaginal secretions are local congestive states of the pelvic organ, such as pregnancy, acquired retroversion, prolapsed congested ovaries, chronic pelvic disease, chronic constipation associated with the sedentary lifestyle. So coming to bacterial infection which causes leukorrhea, they are trichomonas, monilial infection, and bacterial vaginosis. These are the common ones. So in trichomonas vaginalis, there is greenish discharge, dysuria is present, itching is present. When we do a per speculum examination, we can see the cervix and the vagina has red spots, which is also called as strawberry cervix and vagina. So on saline microscopy, we can demonstrate the trichomonas organism. The treatment drug of choice is metronidazole, 200 milligram thrice daily can be given for 7 days. Next, monilial vaginitis, Candida albicans. Candida tropicalis, it is where the curdy white discharge is seen. Vaginal wall is studded with white punctate dots, or you can even get flakes of candidal infection. It can be demonstrated on saline microscopy showing pseudohyphae, and the treatment is fluconazole. It can be given locally. If the symptoms are severe, it can be given orally. Coming to bacterial vaginosis, it is a dirty white grayish discharge, foul smelling, and there is no itching. To confirm the diagnosis of bacterial vaginosis, it should fulfill the Amsel's criteria with the clue cells. Clue cells are vaginal epithelium with stippling because of the microorganism. There is dirty white discharge. WIF test is positive, that is fishy odor on KOH test. Gold standard is Finberg-Wittenberg medium, and treatment again is metronidazole or clindamycin. Colors of vaginal discharge and what they mean. If it is a clear discharge, it's a healthy discharge. It is physiological leukorrhea seen in pregnancy, ovulation, and hormonal imbalances. Gray is bacterial vaginosis. Pink, cervical bleeding, vaginal irritation or implantation bleeding after conception. White again is a healthy discharge, or it can be a fungal infection. Yellow-green is seen in sexually transmitted infection. Red is bleeding, can be menstrual cycle, cervical infection, cervical polyp, endometrial or cervical cancer. Coming to menstrual irregularities, amenorrhea indicates the absence of menstruation. It is a symptom and not a disease entity. Heavy menstrual bleeding is arbitrarily defined as menstrual blood loss of 80 ml or greater, or excessive menstrual blood loss that interferes with women's physical, emotional, social, and material quality of life. Coming to amenorrhea, where there is no menstrual cycle, it can be seen in tumors, Kalman syndrome, weight loss, exercise, panhypopituitarism, Sheehan syndrome. The most common ones we'll discuss, that is PCOD, hyperprolactinemia, weight loss, stress, exercise, Mullerian agenesis, when we can see it is a primary amenorrhea. Arcade syndrome, Asherman syndrome is again secondary amenorrhea. Tuberculosis, radiotherapy, and androgen insensitivity. Imperforate hymen, vaginal agenesis, and cervical atresia. Types of abnormal uterine bleeding are oligomenorrhea, where the cycle length is more than 35 days. Polymenorrhea, where the cycle length is less than 24 days. Menorrhagia, increased menstrual blood flow, increased duration of cycle, or increased in amount of the bleeding. Hypomenorrhea is again scanty bleeding and shorter days of bleeding. Metrorrhagia, irregular bleeding in between the cycles. Menometrorrhagia is increased menstrual flow as well as irregular bleeding between the cycles. So coming to abnormal uterine bleeding, it is heavy menstruation, and it occurs up to 25 to 30% of the women attending a gynecological OPD. It is more experienced in the 35 years to 45 years of age. It is also seen at menarche. AUB is again divided into acute abnormal uterine bleeding and chronic abnormal uterine bleeding. FIGO has given this AUB classification as palm coin. It is a mnemonic which P stands for polyp, A stands for adenomyosis, L stands for leiomyoma or fibroid, M stands for malignant and pre-malignant lesions, C stands for coagulopathy, O stands for ovulatory disorders, E stands for endometrial hyperplasia, I stands for iatrogenic, N stands for not classified. Chronic AUB is defined as bleeding that is abnormal in volume and regularity and or timing for the past 6 months. It does not usually require immediate intervention. Dysfunctional uterine bleeding was a term previously used and now it is not used. So coming to the treatment of abnormal uterine bleeding, treat the cause. First diagnose what is the underlying cause and then treat the cause. Anemia should be treated simultaneously. Medical line of management should be tried first. Medical line of management includes hormonal and non-hormonal drugs. Hormonal drugs includes combined oral contraceptive pills, progestrogens, GnRH analog, Mirena IUCD, that is progesterone impregnated intrauterine contraceptive device. Now, non-hormonal drugs can be tranexamic acid. Minimal invasive surgery, where ablative techniques are used. First generation hysteroscopic ablation of endometrium, resectoscope, rollerball laser. Second generation like radiofrequency induced thermal endometrial ablation, balloon therapy, microablation, uterine tamponade in acute bleeding, bilateral uterine artery embolization. Indications for hysterectomy in abnormal uterine bleeding are when medical management or minimal invasive surgery fails and the menorrhagia recurs, or in older women who has crossed 40 years of age and she is not desirous of childbearing. Coming to contraception and sterilization. A method or a system which allows intercourse and yet prevents conception is called as a contraceptive method. So how a contraception should be decided. So and how it should be advised to a couple. First, the availability and the cost. It should be easily available for the couple and it should be cost effective. Then age and parity of the couple. So we should know what is the age of the woman if she is having and the parity of the couple. I think contraception nowadays should be advised even in the adolescent education because we can prevent so many unwanted pregnancies. We can prevent sexually transmitted diseases in young unmarried girl and a boy by advising them barrier contraceptive. Along with that, we can even prevent the morbidity and mortality associated with the medical termination of the pregnancy she has to undergo if she is unmarried. Then reliability, that is failure rate. Then side effects or contraindication to a particular methods. We should look for the woman's health status so that if she is having contraindications to that particular contraceptive. Then advantages and disadvantages. Then the follow-up requirement when she has to come back and visit the doctor, and counseling. So the natural methods of contraception are abstinence during the fertile phase. So in any given menstrual cycle, a woman will be fertile for some during the ovulatory period and she is infertile during the half of the cycle. So we have to counsel about how to maintain a calendar method. Then withdrawal, that is coitus interruptus, that is the male partner should remove the penis from the vagina and the genital organs of the female and ejaculate outside. So that is coitus interruptus. Barrier contraceptives like male condom, female condom. Male condom is available in all the pharmacies. It is also marketed by in the trade name Nirvodh by the Government of India. Then spermicidal agents, diaphragm and cervical cap. Diaphragm is again a cap-like structure which is placed on the cervix with a spoon of spermicidal agent in that. And cervical cap acts by the suction. It also covers the cervix and it also helps in acts as a contraceptive. Next is intrauterine contraceptive device, multi-load 375 or property 380 are available, which gives a good contraceptive when used. It can be used for 3 to 5 years. It is non-hormonal. Even hormonal contraceptive, even hormonal IUCD is available, as we discussed. That is Mirena. It inhibits the endometrium. It irritates the endometrium. It doesn't provide a good environment for implantation. So by that, it acts as a contraceptive. Hormonal contraceptives, which are available in various forms. Commonly used are the oral contraceptive pills, which has to be taken for 21 days. Combination of estrogen and progesterone, available by the Government of India in the trade name of Mala N and Mala D. Then birth control injections are present, which is depot medroxyprogesterone acetate used in a dosage of 150 milligram given once in 3 months. Then vaginal ring, which also has estrogen progesterone components, contraceptive patch. Another important contraception is postcoital contraception or emergency contraception, easily available by the Government of India. It is easy pill. In the pharmacies, it is I-pill, and it is given within 72 hours of the last coital act, and it is the drug is levonorgestrel 150 mcg. Then lastly is the permanent sterilization. Definitely this is advised for a couple where they have completed their family and they want a permanent contraceptive method. So it can be a tubal ligation, fallopian tube is ligated in women, or a vas ligation, that is vasectomy. Long-acting contraceptives are oral tablets, 3-monthly injections, again implants, IUCDs, and surgical methods. Short-acting contraceptives are condoms, barrier methods, postcoital, daily pills, and skin patches. So where all they act? Oral contraceptive pills and hormonal contraception, they act on the anterior pituitary. Tubal ligation is a tubectomy is on the fallopian tube. IUCD on the endometrium. Cap diaphragm spermicides on the cervix. Coitus interruptus and condom and vas ligation are the male contraceptives. Coming to the menopause. So this is the last part of the lifespan of a woman. Definition: cessation of ovarian function leading to permanent amenorrhea. So there is something called as climacteric phase, which is a phase of waning of ovarian activity and begins 2 to 3 years before menopause and continues for 2 to 5 years after that. The range of menopause in women is 48 to 52 years and the average age is 49 years. So what are the clinical features of women faces? They are hot flushes, sweating and insomnia. Hot flushes, this is a change in the estrogen progesterone ratio. There is reduction of the, increase in the norepinephrine levels. So there is vasoconstriction of the face and the neck area, which causes hot flushes, followed by which there is a vasodilation, which leads to sweating. All this conditions leads to irritability in the woman and insomnia and headache. There is dyspareunia and decreased libido. Decreased libido, again, there is fall in the hormones. Dyspareunia, there is atrophy of the vaginal epithelium. There are decreased, the glands and endocervical glands, endometrial glands have decreased their secretions. So there is dyspareunia. This leads to irritability, depression, tiredness, loss of concentration and loss of memory, and also urinary stress incontinence. Later effects of menopause. There is arthritis, osteoporosis, fractures, and backache. The bone mineral density start to reduce at the rate of 3% per year after a woman attains menopause. There is increased incidence of ischemic heart disease, atherosclerosis, hypertension, and stroke. All this is because we know that estrogen is a cardioprotective. So as there is fall in the estrogen levels, the incidence of these diseases increases. Also, there is hypothyroidism, diabetes, and skin changes. There are also Alzheimer's disease, colonic cancer, tooth decay, stress urinary incontinence, fecal incontinence, cataract, glaucoma, macular degeneration, and also malignancies. The leading cause of leading malignancy in women is breast cancer, followed by cervical cancer, colorectal cancer, uterine cancer, and lung cancer. So treatment, hormonal replacement therapy. So which women require hormonal replacement therapy? Only when the woman is symptomatic, she has hot flushes, she has headache, insomnia, osteoporosis, she may need hormonal replacement therapy. And hormone replacement therapy is only given for a short duration of around 3 to 6 months. There is natural estrogen present, which is given in the dose of up to 0.625 mg per day. If the woman is not hysterectomized, progesterone, that is duphaston or medroxyprogesterone acetate 10 milligram can be added to the last 10 to 12 days of the cycle. If she is hysterectomized, no need of progesterone. That the estrogen replacement therapy is also available in the transdermal patch, which is available as 50 milligram patch. It should be applied twice a week, which is very costly. Vaginal cream for if she is having dyspareunia, atrophic vaginitis, Permarin as a vaginal cream is available. There are implants also available. Bisphosphonates, the drugs used are ibandronate or elandronate, which is used to prevent osteoporosis in women, which should be substituted along with calcium and vitamin D. Coming to postmenopausal bleeding. So any vaginal bleeding which occurs after 12 months after the cessation of the menstrual cycle. If she has attained menopause and she is not bled for 1 year, and if she starts to bleed after a duration of 12 months, then it should be labeled as the postmenopausal bleeding and she has to be evaluated. So which are the common causes of postmenopausal bleeding? They are malignancies, carcinoma of the endometrium, carcinoma cervix, CA ovary, CA of the vulva, vagina, sarcoma of the uterus. Benign causes are endometrial hyperplasia, endometrial polyps, fibroids, decubitus ulcer in a prolapsed uterus. Infections like pyometra, tuberculosis, senile vaginitis, senile endometriosis. bleeding from the urinary tract or the anal canal, and irregular intake of hormone replacement therapy. So how do you evaluate her? So first, a history should be taken of the duration and the severity of the bleeding. Associated symptoms, like we want to rule out malignancy, we have to ask if she's having loss of appetite, loss of weight along with any palpable mass. Then past medical or surgical history, whether she was on hormone replacement therapy or not. Surgical history, if she's a known case of malignancy and she's operated for any of the malignancies. Then family history of colorectal, endometrial or other cancer associated with hereditary non-polyposis colorectal cancer, or it is also called as Lynch 2 syndrome. So the clinical features will be, there may be abdominal pain or the bleeding may be painless. She may have even postcoital bleeding. There is foul smelling discharge. There may be urinary and rectal symptoms. So how all we have to investigate her? Routine investigation is done, like for routine CBC, RBS to look if she is diabetic. Then a cervical cytology, that is a pap smear. If we are not able to see any lesion on the cervix, it is better to take a pap smear. If there is a lesion on the cervix, we may suspect it as a cervical carcinoma and we can take a biopsy directly. Then outpatient hysteroscopy to rule out if there is any endometrial polyp. Biopsy as indicated. Coming to the management, treat the cause. If it's a benign cause like atrophic vaginitis, we can give her estradiol cream, vaginal ring or patch. If there is a cervical polyp, polypectomy can be done. Endometrial atrophy, again, estrogen replacement therapy should be advised. When there is endometrial hyperplasia, if that is a postmenopausal woman, we do ultrasonography, the endometrial core is more than 4 mm, better to go for an endometrial biopsy to rule out if it is just a benign endometrial hyperplasia or it's a malignant carcinoma endometrium. So coming to the malignancy, so malignancies are more common in the postmenopausal age group. It can be CA cervix, CA ovary, CA vulva and vagina, or sarcoma of the uterus. As discussed earlier, leading cause of CAM malignancy in women is breast, followed by cervical cancer. So how they present? Most of the malignancies in gynecology, they present as postmenopausal bleeding because it is either CA endometrium or CA cervix. And the other malignancy, the CA ovary, will present as mass per abdomen, or she'll have vague complaints like loss of appetite, loss of weight, or it may be an incidental diagnosis of CA ovary. So on examination, clinical examination, per abdomen examination, we may be able to palpate a mass. For per speculum and per speculum examination, we may able to see a cervical growth. If it is an endometrial malignancy, it is diagnosed on ultrasonography. So investigation, blood count and smear, blood glucose level, cervical cytology and cervical biopsy, endometrial tissues sampling, solar salpingography, ultrasound, CT, MRI whenever required, tumor markers. So in gynec, the tumor markers which we want to see are CA125, which is most often increased in epithelial ovarian tumors. It is more than 200 if it is confirmed that it is a ovarian malignancy. Apart from that, we alpha fetoprotein and LDH or beta HCG, which are common in choriocarcinoma. Alpha fetoprotein is seen in embryonal carcinoma or immature teratoma. Coming to the treatment, treatment for malignancy, definitely it has to be evaluated. If it is a CA ovary, it is a staging laparotomy is done. If again a CA endometrium, staging laparotomy is done, and if needed, depending upon the stage of the disease and the age of the woman and the metastasis of the malignancy, a chemotherapy and a radiotherapy are always considered. So it is definitely a difficult thing to manage because surgical management followed by chemo and radiotherapy. So this is common gynecological problems which we can encounter in the whole lifespan of a woman. Average lifespan of a woman is 65 years, but nowadays many women are crossing that age and living up to 85, 90 years of age. So these are the different problems we encounter in our day-to-day practice. So with this, I would like to end my presentation.
Hello.
Hello. Yes, ma'am.
Hello. It was a really wonderful presentation by Dr. Anita. Actually, it is a very vast topic. She has attempted to cover almost everything. So few things I would like to share is, since it is a mixed forum, like not only obstetricians, other branches, doctors are also there. So these gynec patients, they literally come to each and every one of us. So each and every one of us will have faced all these situations in our day-to-day practices. When you're seeing adolescent girl coming to OPD, suddenly she comes from the school and college, like crying, many attenders come with her. They get her, like she's having severe dysmenorrhea, she's fallen down, she's having giddiness, all those things. This is a common picture what we say in our day-to-day practice. So most of the time, these adolescent girls, like Anita said, you have to just rule out what any pathology is there. So most of the times, more than 50% of the cases, it is just like a normal thing. So more than treatment, some amount of reassurance is needed for such patients and their family members also. Actually, they are more tensed and they are more anxious. So they have to be advised, like along with the antispasmodics and the analgesics, they have to be advised like a good nutrition and good hydration, and they have to be given proper education. So that is the thing. And nowadays we have seen that we are having more of a precocious puberty kind of thing. They are starting periods at a very early age. Previously, like it used to be more than 10 years of age, almost most of the times. Now we have seen 5th, 6th standard, the girls are in 5th and 6th standard, and they're started having their menses. So such very young girls, they need some amount of support and education and things like that to manage. And also the abnormal uterine bleeding also, age-wise, you have seen many young girls come with menorrhagia and symptoms like that. So as gynecologists, we just diagnose what is the exact cause. Most of them, like it will be fine. There is no much treatment or this thing needed. So reassurance is needed and some amount of hematinics and education is required. So when you come to the early 30s and the late 20s, what happened? We have seen many women coming with the pain abdomen. You see, they come to every OPD with pain abdomen. Surgeons and physicians might also experienced such things. They come with pain abdomen. Pain abdomen, like it will be so severe and so long-standing that most of them have it in mind. They have to undergo hysterectomy. Something is wrong with the uterus. Most of the time, they'll be having that in the mind. So such cases, when they undergo the ultrasound, things turn out to be normal. Then they'll just be surprised, like why everything is normal, but why I'm having the pain. So most of the times they'll be like malnourished. They'll be having some UTI, gastritis. All such things need to be treated. And first they have to be told that, see, your uterus is fine. And once you do a pap smear, you will come to know whether her cervix is good, and reassurance is required. Otherwise, what they'll do, they'll have it in mind. So one neighbor has undergone hysterectomy, even I have to undergo hysterectomy. So we have find that many women are undergoing hysterectomy these days at a very young age. So that is very harmful for them, that they don't realize. In later life, they are going to face many difficulties because of the early hormone depletion. And one more thing I would like to say, that many patients come with a scanning report, ultrasound report. Such women, like there is an ovarian cyst, the radiologist doesn't know. He just like mentions whatever is there. Just a 3 functional cyst will be there, 3-4 centimeter, 5 centimeter also cyst. So nothing is there in the report except for the cyst. So what happens is suddenly, like, oh, there is some cyst inside, I have to get operated. Some cyst inside, they have to get operated. So this is the thing that goes into their mind. So I think almost all the practitioners have gone through all such problems. And one more thing is, Dr. Anita, as she was telling, was about the adolescent contraception. That's, I think, in the past 4 to 5 years, there is a need for adolescent contraception. Previously, actually, the new MTP rules, what it says that we can offer MTP services up to 24 weeks for any unmarried woman who is a major, who has crossed 18 years of age. When the woman is less than 18 years, so the teenage pregnancy, only then we have to take permission from the, like we have to report it to the police. and do accordingly. So the liberalized rules are there, MTP rules. So like we have to, like, it is actually a boon for the gynecologist. Most of the time previously, like they used to come very late and all those things were there. And even for the anomalies, we have diagnosed many anomalies very late. So the liberalized MTP Act up to 24 weeks, what they have given is truly beneficial. And adolescent contraception, actually we should speak openly to the teenagers and especially the unmarried girls whenever they come to our OPD with some amount of UTI, wide discharge. They'll not open up soon, but we have to take an adequate history and offer them contraception. And even if we offer them abortion, we should counsel them regarding adequate contraception also. And another thing I want to like to say is how menarche has become very early these days. Even the menopause has become early. We have seen many women whose ovarian reserve is coming down rapidly. So many infertility patients coming to the infertility OPD. What happens is you are seeing that their AMH is very low at the age, just at the age of 30 and 35 years. So I don't know why this is happening, is all because of the lifestyle or the food habits and the sedentary life. I don't know what are the factors which have environmental factors are playing a role in this. So we are getting many cases of low AMH these days, and precocious, like early menopause is there. So what we can do is see, we can't stop the menopause and we can't give them HRT for a longer period. At the most, what we can do is we can give them good supplementation as well as lifestyle modifications regarding the diet and the exercise and the obesity, the central obesity which develops after the menopause. We have to educate them regarding that and treat accordingly. And whenever middle-aged woman or in the 30s, 40s, she comes to our OPD, we should make it a point to examine the breast and examine the cervix at least, because they don't come to you like you just screen me for any malignancy. If you utter the word malignancy, they'll run away. So you just take it this thing to take an advantage of they coming to the OPD to see that whether they have anything in the breast or the cervix, and you just put a probe and see how's the uterus and things like that. Dr. Anita done a good job. And one more thing I would like to say is the adolescent age group, you can advise them the HPV vaccine also. There is not much, very much this thing these days, like everyone is not taking. So we should make it a point that we at least counsel them regarding that.
Yes,
advise them. Thank you.
I thank Dr. Lakor sir, Dr. Kiran Kumar sir, Dr. Madhusudan sir, Dr. Shubha ma'am for advising so nicely about the points and summarizing it actually. I also thank Dr. Sanjana ma'am for giving me this opportunity to come and stand on an IMA platform. And
Any
thank you.
questions?
Yes, ma'am. Any questions?
Any questions?
Sanjana ma'am,
Yes, sir.
you need to start a course.
On
Gynecology, study gynecology in half an hour.
ಎಲ್ಲ ಕವರ್ ಮಾಡಿದ್ದಾರೆ ಸರ್ half an hour ಅಲ್ಲಿ.
That's what I said. Short course in gynecology.
Both are good. They have covered everything in half an hour. One
Well,
year
madam-
ಬೇಕು ಸರ್ full whole topic cover ಮಾಡಕ್, but half an hour ನ cover ಮಾಡ್ಯಾರ. What are the anxiety symptoms in menopause?
Ma'am, irritability, insomnia, and the fear of malignancy, the fear that she is losing her feminine picture. All these things are present in perimenopause and menopause, that climactic phase where she's changing from whatever she is losing her menstrual cycles. So there will be anxiety. These are the symptoms of anxiety in menopausal age group.
What treatment you want to give her, or what advice you want?
Ma'am, most often, if we reassure her, it is enough. Sometimes anxiolytics may also help. Simple alprazolam also may help. If needed, selective serotonin reuptake inhibitors are safe, but for a shorter duration, because eventually she will get accustomed to that lifestyle. Only during that change of her body and her behavior, it will take little time to adjust to that. As I said, fluoxetine or sertraline is available, we can advise her. But that also is a reassurance is a major treatment for her.
Many of them want to take the anxiolytics continuously. They are so much used to it.
Dependent on that.
Once you start them on anxiolytics, they feel very comfortable and they want to take it throughout the year.
Can we treat palpitations?
I think reassurance will help, but
Yeah. Okay. So once there is too much of tachycardia, you can start them on low dose of beta blockers also.
yes, ma'am.
Both are physician's wife, so they can guide in that sense also. One is cardiologist wife, Dr. Anita Gaura, and one is physician's wife. So the both can guide us in palpitations also. Okay.
Metoprolol we can use. Metoprolol can be used.
Madhu sir?
ಏನಿಲ್ಲ ಮೇಡಮ್ ನಥಿಂಗ್ ಅಲ್ಲ what are the causes for the precocious puberty that we see now?
Sir, it is basically the body weight, sir. Body weight. Actually, these are all the hormones are steroid based, sir. That is the thing. So you can see, sir, most of the kids, when we were kids, we were not having so much of weight at that age. Now kids, like young girls at 8 to 10 years also, they are like weighing 30, 40 kgs, 40, 50 kgs. Their weight is more, sir.
And also, I think little exposure
obesity.
to the media, I think, sir. Axis, that HPO axis is getting alert very, very younger at a very younger age.
More
So
of
much.
cholesterol, more of this thing.
This childhood obesity has become a major problem actually for everyone. There is not only because of it is we as a mother now, this generation parents who are early diabetic, gestational diabetes, that incidence also increases. That indirectly contributes to the childhood obesity. Apart from that, the food which we are taking is more of the children. The food which they are consuming is more of ready-made and more of junk, which is also affecting their obesity. And as madam said, the media effect is also there, which is increasing their HPO axis, which they are going for early menarche.
Right. Sir, shall I end?
Okay, madam.
Okay. I thank Dr. Anita and Dr. Shubhas for completing or touching everything in gynecology. So before Anita said, like, Madam, bahut doddu topic adari, but she has explained briefly, and I think Shubha has shared very well and elaborated everything along with her. So thank you both for a brief interactive session on gynecological day-to-day gynecological problem. I thank our President sir, our Secretary sir, and Madhusudan sir for giving opportunity for all of us on this platform to perform ourselves or to say few words, and all the people of IMA KSB for making this and supporting us. So I thank each and everyone for your support. Thank you, sir. Thank you. Arun. I thank Arun and John. John, I think we are missing you. So Arun.
Yeah, ma'am.
Arun is there instead of
Yes,
John.
ma'am.
So thank you.
Thank you.
Thank
Very
you.
informative.
Good night, sir.
Thank you. Thank you.